good morning to Miss Po Ching Huang. I am Irawan Wibisono from Fisioterapi Widya Usada Semarang, and here I'm as a moderator for this seminar. Before we start the event, I have introduced about you to all the participants earlier this morning, and I would like to ask permission because I think and we think this what is it? Lecture is important for us. I would like to ask permission to be a translator about this lecture. And if you're okay, and I will be the translator for this event. Okay, because in Indonesian at 12 o'clock we have a prayer. So this lecture will be ended at 11 or at least 11:30. I hope this is enough time for you to give us a lecture. So for the time and the next event, I give to you to continue this lecture. Thank you.
Should we start in 11 o'clock or now?
We start now and will be ended at 11 o'clock.
Excuse me. Because we have different time, so 11 in Taiwan, it means 10 in Indonesia. So we have different 1 hour's time. So we will end at 12 in Taiwan, Rahel. Did you understand?
Yeah.
Yeah. So we have the different. So it means the moderator says 11. It means the Indonesian time, not Taiwan times.
Yeah, sure.
Okay. Thank you.
So we will start after five minutes or now?
Yeah, after 5 minutes, because the moderator will introduce you first and just a brief information about the speakers.
Okay.
Okay. Monggo disilakan Mas Irawan, dilanjutkan.
Oke. Sebelum saya mulai, Pak Rahmat apa jenengan atau saya?
No, it's okay. Nggak ada masalah. Go ahead aja.
Oh iya. Tapi nanti kalau saya banyak miss ya, Pak.
Nggak ada masalah. Beliau ini mohon izin agak terlalu cepat untuk berbicara, jadi mungkin moderator memberikan note di akhir perkuliahan atau di akhir speak dari pemateri, karena beliau terlalu cepat untuk berbicara, biasanya seperti itu biasanya. Dilanjutkan aja Mas Irawan.
Oke.
Irawan, mohon maaf Pak Irawan, mohon maaf.
Sama aja Pak. Rambutnya sudah potong ya Pak Rahmat tadi ya.
Ayo, monggo.
Oke. Ini saya introduce dalam bahasa Indonesia atau bahasa
Indonesia saja enggak apa-apa.
Enggak apa-apa ya. Oke. Saya ulangi lagi, tadi ya saya sudah perkenalkan tentang Miss Po Ching Huang-nya.
Ya.
Okay, Miss, you can start the meeting right now.
Okay, thanks for everyone being here today. So our topic today is early mobilization in the intensive care unit, and I'm Po Ching Huang. I'm from the Institution of Allied Health Science in Taiwan.
Ya, ini untuk saat ini pemaparan materi akan langsung dimulai oleh saya, Mrs. Po Ching Huang dari Taiwan.
Mohon izin, sorry.
Okay.
I will cut for this. Mas Irawan, nanti mungkin Mas Irawan mentranslate-nya setelah perkuliahan, bisa begitu?
Oh, oke. Jadi setelah selesai baru ya?
Iya, dibikin note saja, nanti poin-poin di slide berapa nanti dijelaskan mungkin dengan bahasa Indonesia, karena sedikit agak terganggu untuk setiap slide diganti, begitu nggih? Saya akan menyampaikan ke pematerinya. Rahel, I think after your speech, everything, after your presentations, the moderator will be, like usually, will be translate in Indonesia, because we have misunderstood at first. The moderator will translate everything, every one slide. So I think it takes time. So probably it's better that after your speech, the moderator will be give any pointed from your presentation. Is it okay? It's like
Yeah.
usually class. Okay. Okay.
Should I stop in the middle for the translation?
I think for you have 30 presentation. Is it okay? Yeah, 30 or 35 presentations.
Yeah, 25.
25. So for 12 presentations.
I think will be enough.
Okay. Okay. Okay.
So should we pause in the middle?
Yeah. What pause in the middle? Is it okay?
Okay.
Okay. Go ahead.
Okay. Okay, so let's start today. So today we talk about early mobilization. So for early mobilization, sorry. Okay. So for mobilization, it means the global definition as the physical activities. Sorry. Okay, so the global definition of the mobilization is as the physical activity that performed with the appropriate intensity and produce the physical benefits of the organism. So for early mobilizations, it includes it's the activity that are carried out from the initial physiological stabilizations and that's continued during the ICU stay. So it includes the activity that produce movements such as active limb exercising and moving or rolling in the beds or sitting on the edge of the beds, which acting on the circulation, central and peripheral perfusion and ventilation or the state of consciousness. So do you want to explain now or after few slides?
After a few slides.
Okay. Okay, so we talked about who needs early mobilization. Early mobilization usually designed for patients who will stay immobilized for a period. Like after the surgery or stroke, the patient might rest in the hospital or in home for very long times. And also for someone who's admission for chemotherapy, like for cancer patient. For these kinds of patient, we are recommended for patients to receive the early mobilization. And today we focus on a group of the patient who stay in ICU, because the patients stay in the ICU, they are generally weaker than other patients, and also they are connecting to lots of the life support machines. And also, they might stay in ICU for a long time, so they might be prolonged immobilized due to their disease and also because of the supporting machine. Okay, so we talked about why does patient needs early mobilizations. In here, we talked about this one of the symptoms of phenomena. We say in here is the intensive care unit acquired weakness. We call it ICU-AW. So in ICU-AW, we have divided into 3 subgroups. The first one is critical Eo polyneuropathy. It is the symmetric weakness caused by the denervation. And the other one is the critical illness of myopathy. It is the weakness of the limb and the respiratory muscle, and which is more common than the polyneuropathy. And then it's the critical Eo neuromyopathy. It's the combination of the above two. So the incident rate of the ICU-AW is about 40% according to the systemic review papers. And a survivor of critical illness experience a marked disability and impairment in physical and cognition function that will persist for years. So the ICU acquired weakness is a result of a number of the pathophysiological mechanisms, and more than one mechanism may affect an individual patient during the treat in an ICU. So in early study, they identified the critical Eo polyneuropathy. and which is characterized by the symmetry weakness of the proximal limbs muscle through the denervation and denervation atrophy. It might also affect the respiratory muscle and delay the weaning from the mechanical ventilation. And then they have divided into the other group is the critical Eo myopathy. Critical Eo myopathy is a primary myopathy that is different to distinguish from critical illness polyneuropathy. And critical Eo myopathy is more common than the critical Eo polyneuropathy, but presents with similar weakness of limb and the respiratory muscle. And these two conditions could coexist, and although they could be characterized and differentiated by the electrophysiological studies and the muscle biopsy analyzed, such evaluations are often not technically possible in a critical ill patient. So we have to we just have a concept about intensive care ICU acquired weakness, that they might have the weakness of the muscle, and also it might affect the respiratory muscle, which cause the patient to deliriate really fast. Okay, so what is the ICU-AW? It is associated with musculoskeletal, vascular, pulmonary, and metabolic and physiological problems. For musculoskeletal, the patient might suffer from joint construction because joint construction or muscle atrophy because the immobilized a long time. And for vascular, they might have the thromboembolysis or the microvascular alterations. And for pulmonary, the patient might suffer from atelectacy or pneumonia or insufficient breathing function. And for metabolic, the patient might have the resistance to the insulin. And for psychological problems, the patient might have the delirium, agitation, or the depression due to the long-term stay in the ICU and just facing the nursing and just the machine. So patient may also have some psychological problems. And all of these problems will worsen patients' condition and even increase their mortality rate, because it also causes like bed sores or loss of circadian rhythm. And all of this might extend the weaning period and development of disabilities, results in a longer hospitalization, and even the worst part is to increase their mortality rate. Okay, so for the ICU-AW, the risk factor including prolonged inflammation or sepsis, and also the immobilities, and the prolonged mechanical ventilations, and uncontrolled hypoglycemia or treat with glucocorticoid or neuromuscular blocking agents. And risk factors are above we mentioned here, but for the first three conditions, it is pretty common in the ICU patients. So for the ICU-AW, it is easy to develop, and the incident rates, like I mentioned before, like about 40%. Okay, so we summarize for the ICU-AW. That is no specific intervention has been shown to prevent ICU-AW. However, current strategy to limit the development of ICU-AW is an optimized recovery from the critical ill are focusing around minimize the sedation and targeting on early mobilization of the patient. So in here, rehabilitation and early mobilization are considered to be the therapeutic strategy to prevent the development of ICU-AW. Should we pause here? Rossetti, should we pause here or should I continue?
Okay, thank you. Maybe pause a bit. I will try to give a resume until now, so the participant can follow.
Sure.
Okay, I give some note. Oke, di sini kita akan membahas tentang early aktivitas ya, atau aktivitas awal yang dilakukan oleh seorang fisioterapi. Dan ini direkomendasikan bagi pasien yang setelah mengalami stroke atau pembedahan. Nah, mengapa perlu? Karena biasanya pasien-pasien tersebut mengalami kelemahan dan penggunaan mesin secara terus-menerus, serta kurangnya gerakan. Lalu untuk aktivitas atau early mobilization atau aktivitas awal ini biasanya digunakan untuk pasien-pasien kondisi polineuropati, miopati, ataupun gabungan keduanya. Dan di sini, di poin selanjutnya, dan mengapa perlu latihan ini? Karena di sini biasanya berhubungan dengan kondisi pasien yang terus menurun. Karena kondisi pasien terus menurun, maka akan meningkatkan angka kematian. Dan gangguan-gangguan yang terjadi pada pasien ini biasanya sifatnya tidak hanya satu, tetapi multi. Jadi mulai dari gangguan pada muskuloskeletal, lalu ada gangguan pada pembuluh darah, pada sistem pernapasan, metabolis, dan bahkan pada gangguan psikologis. Psikologis ini biasanya adalah gangguan dalam bentuk depresi dengan kondisinya, gangguan secara mental. Nah, selanjutnya di sini poin yang lumayan penting adalah, nah, untuk penggunaan di sini tidak ada satupun intervensi yang spesifik yang bisa mencegah terjadinya penurunan penurunan kondisi pada pasien di ICU. Jadi tidak ada spesifik intervensi yang khusus. Tetapi di sini lebih ke arah untuk mengulangi penurunan kondisi, dan targetnya adalah sebisa mungkin, sedini mungkin pasien dapat melakukan mobilisasi. Nah, dan di sini fungsinya ini adalah sebagai strategi untuk mencegah terjadinya penurunan yang terus-menerus, yang secara progresif. Oke, I think that's from now. You can continue your lecture.
Okay. Thanks for the explanation. And here we talked about when should start early mobilization. So now the more research started to conduct in early mobilization, and there are also some systemic review article has come up with an optimal times for the initiation of the early mobilizations. So in the UK National Institution for Health and Critical Excellence, they have recommended that the early mobilization should start as early as possible during the ICU stay. And there are some article after some systemic review article trying to compare the goods and the bads for early mobilization. They have come up with the conclusion is that the initiation of the mobilization within 48 to 62 hours of mechanical ventilation might be the optimal for improvement of the clinical outcomes, and it should be last until patient discharged from the ICU. Okay, so here we have one of the article, this one we can see here, and they have conducted early mobilization to finding out that it might improve the extubation outcome on critical ill patient in the intensive care units. So the results here, we could see that they have divided the patient into the control group, that is not receiving early mobilization, and the intervention group is receiving of early mobilization. And they find out that their duration of using mechanical ventilation has significantly the duration of using a mechanical ventilation have a little bit increased, but their rapid shallow breathing index has significantly lower, and their extubation value rates. Their expiration value rates has significantly lower than comparing to the control groups. Sorry. Let me explain again. In here, the control group didn't receive the early mobilization, and in the intervention group, they have received the early mobilization. And to comparing their days of using a mechanical ventilation, we found out that the results had no significant difference. However, their rapid shallow breathing index has significantly lower, and their extubation failure rate also has significantly decreased. So the conclusion of this study finding out that the chest physiotherapy with early mobilization could improve the patient's extubation rates for the patient in the ICU. Okay, for the other, this one article talks about the early mobilization for the critical ill patient in ICU, and they're trying to use a systemic review and meta-analysis to finding out the advantage of early mobilization. And they have included 23 studies and finding out that with the early mobilization, it might decrease the incidence of ICU AW. It also improved the patient's functional capacity, and also increase the number of patients who are able to stand in the ICU when they stay in ICU. And also it increased the number of the ventilation-free days. And also it increased the discharge rate. So the above is the advantage of the early mobilization. Okay, so should we pause here? The next up, we are going to talk about the stage of the grading for the patient to receive the early mobilization.
Okay, maybe I can give some explanation.
Yeah.
Point-point. Ya, untuk yang poin pertama di sini saya akan menjelaskan bahwa di sini ada kelebihan dari early mobilization, yaitu di sini berdasarkan penelitian yang dilakukan pada tahun 2018 pada pasien latihan mobilisasi pada pasiennya yang mengalami gangguan di pernapasan. Di sini dengan latihan early mobilization meningkatkan rate extubation rate. Meskipun di sini untuk durasinya tidak ada perbedaan, tetapi extubation-nya terjadi peningkatan. Lalu ada penelitian lain di sini ternyata early mobilization ini bisa meningkatkan functional capacity, meningkatkan kemampuan pasien dalam berdiri, lalu mereka di sini penggunaan ventilatornya itu menjadi lebih sedikit, dan di sini peningkatan kondisi pasien sehingga mereka lebih cepat untuk pulang ke rumah. Okay, you can continue from now. Thank you.
Okay. Okay, so for the next, I want to know, can you see the point of my mouse on the screen?
Okay, I can see.
Yeah, sure. Okay, so the next part we're trying to, I will try to provide some condition for you to divide the patient into 4 levels, and for different levels of patient, I have scheduled some of the early mobilization programs. So in the future, if you go into clinic, it's usable. So the first level of patient, that is when patients stay in the ICU and there are consciousness, then we will divide these kinds of patient into level 1. And for level 1 patient, they can also have they could only perform passive extremities ROM. That means patient is unconscious and is not able to perform any physical activities. So this for the level 1. Okay, so for the level 2 patient, the patient is consciousness clear, and patient could perform a little bit the active extremity ROM. However, we see this picture here. This is actually too active for a patient to stay in the ICU. It's maybe not like this. For level 2 patient, they might just they have acting as their consciousness is clear and they are okay to following the simple commands with PT, and they might able to perform the sitting position on the bed. But it's sitting on the bed, not on the bedside. So just the patient could tolerance for the elevation of the bed, and it could be in a sitting positions on the bed. Okay, so for the level 3 patient, the patient is able to sit on the bedside. So the level 3, the patient is similar to the level 2, but the activation level is higher. The patient is able to sit on the edge of the bed, and the patient's bicep strength is about 3 points on the muscle powers of MRC, we could see here. So for the level 3, the patient is able to move against the gravity, however, is not able to move against the resistance. So for the level 3 patient, a patient might have the bicep strength for like 3 points. Okay, here, and this is the last stage, the level 4. The level 4 patient will be able to transfer to the chair. So patient is more active than level 3 or level 2, and it is active moved from the bed to the chair. And their quadriceps strength might also need to be the grade 3, like it's able to resist the gravity but not able to resist for the resistance. So the above is the full level of the to grading the patient who might going to receive the early mobilization. And then following, we were trying to talk about for the different levels of patient, what kinds of the early mobilization we could provide. So for the level 1 to level 2, for level 1 patient, we remember the patient is about the patient level is unconsciousness. So we could just only provide some passive physical therapies for patient and trying to improve to maintain their chest wall, their pulmonary functions, or trying to using some manual techniques to improve, to maintain, or to help their respiratory function. So the first one we could do is the rib cage compression. It is trying to help the rib cage using our hand force to providing the passive stretch of the rib cage and try to help for the chest wall expansion. So first one is the rib cage compression. We could just following the patient's breathing pattern, usually controlled by the ventilation machine. And when patient was exhale, we could trying to compression the rib cage. And at the before patients start to inhale for the next breathing, we could try to do a quick stretch and help the respiratory muscle to co-contraction together. And the second one is the posterior drainage. Because patient is sedation for a long time, so they might maintain in one position for a long time, which is easily for the subputant to accumulate at certain parts of the lung. And in here, we could try to use to locate the location of the subputant, and to using some like pillows or the move of the bed, the level of the bed, trying to providing some postural drainage for the patients and help them to execute their subputant. And also in here, we have to be careful is that for patient, they might have maybe some pressures problem. So before trying to do the postural drainage, before to adjust their posture, to remember that always consider a patient's vital sign has to be stable, and also the posture maintenance time should not pass more than 10 minutes. It is more safety to perform the postural drainage. Okay, then the number 3 is the next is the secretion removal. That is very easy. It is the subputant removal, and in Taiwan it usually performed by the nurse. However, with PT in Taiwan still have learned how to remove the secretion from the suction of the hospital. And here I'd like to give a advice is that always remember to keep the secretion tube to be clean, because for the patient who stay in ICU, they are more weakness than the other patients, and they are easily to develop some pneumonias. So the secretion removal, during the secretion removal, the cleanness of the tube is very important to protect the patient from the further infections. Okay, so for the next one, that is the passive range of motion exercise is help to prevent patient from the joint contractures. However, it's not able to prevent patient from the muscle atrophy. So we're just trying to move any joint, all of the joint of our upper and the lower extremity, and trying to avoid the joint construction, which is very important for patient in a level 1. Okay. Okay, and for patient for level 1 or 2, if the patient level is more active, that patient is during level 1 to level 2, we could start doing some inspiratory muscle training. And inspiratory muscle training is usually to use this kind of device we call the inspiratory muscle training device. And for this device, it could connect it to the ventilation machines, and it could providing some resistance. So for the patient when the patient trying to start their spontaneous breathing, and this could be helped to train for the inspiratory muscle force. So the first one, the inspiratory muscle training, we usually use this kind of device. And for second one, the manual hyperinflation. The manual hyperinflation and the ventral hyperinflation are the manual driven and the ventilator driven chest wall physical therapy techniques. They are used by the physical therapists for the improved chest expansion and the sputum removal in the ventilated patients. So a deep inspiration followed by a quick expiration was introduced with these techniques. The effectiveness of this technique in removal sputum and the reversed atelectacy in the ventilation patient are well proven by the research study. And they are also increased the successful rate in the extubation, so as to winning of the ventilations. So for manual hyperinflation, because the patient, when patient is sedation, the patient is under sedation, their ventilation, their respiratory, using a ventilation machine to adjust, and their breathing level will not be so deep. So using a manual hyperventilation is that we're using these airbags here and switch machine into the spontaneous breathing, and the physical therapists will help to do a manual hyperinflation to help the lung to expand fully. So the patient's lung will prevent the atelectacy and also improve their chest wall expandation, which is good for their next stage, it's trying the winning. Okay, and the third one is the chest wall mobilizations. A chest wall mobilization in here, we were trying to do some like rib cage mobilization, or trying to do some segmental breathing to help their rib cage to regenerate and to regain their functions or their movements, because we know that during the breathing, the rib cage might slightly expansion, and for patient immobilized for a long time, the chest wall might be stiff. So in the chest wall mobilization part, we're trying to regenerate the range of the chest wall expansion. And then the next part is the coughing function training. In this part, patient will start to learn about the chest wall, to learn about the cough. And we were trying to ask patient to inspirate a little bit air, and then hold for a bit, and using the abdominal force to cough out. And in this part, we were trying to train in patient's diaphragm, because using the ventilation machine, the diaphragm might be wasting. And after during the training of the cough function, they might start to recall the diaphragms to contraction again. So also helps patient to train for the next steps of winning. So also some early mobilization, the part that we mentioned before, or doing some RM exercise. Okay. Shall I start here? Stop here because the next part we're trying to talk about more physical activity.
Mas Irawan, di-translate dulu.
Oke, I will translate. Ada poin-poin. Di sini kita akan membahas latihan-latihan yang akan diberikan. Yang pertama akan dijelaskan dulu. Ini ada level-level kondisi pasien. Itu ada 4 level. Kalau level 1 itu pasiennya kondisi tidak sadar. Dan di sini karena tidak sadar biasanya ekstremitasnya pasif. Nah, untuk level 2, pasien dengan level 2 ini adalah kondisi aktif, sudah mulai aktif dan dapat mengikuti perintah-perintah simpel tapi dia masih berada di tempat tidur. Nah, jadi di sini level 3 pasiennya sudah bisa duduk di samping tempat tidur dengan parameternya sini MMT dari bicep ya. Bicepnya itu sekitar 3 sampai 5 kekuatannya. Lalu level 4 ini pasien sudah bisa pindah ke kursi. Jadi duduk di kursi dan di sini parameternya adalah kekuatan MMT dari quadricepsnya dari 3 sampai 5. Nah, level-level ini berguna untuk menentukan latihan apa yang tepat untuk kondisi pasien. Dan latihannya ini yang pertama kita membahas untuk latihan dari level 1 sampai dengan level 2. Nah, di sini untuk latihannya karena pasien pada level 1 itu kondisinya pasif, maka di sini latihannya untuk maintenance atau menjaga kondisi pulmo atau pernafasan. Karena pasiennya kondisinya pasif ya, seperti tadi sudah saya bahas. Nah, latihannya di sini tujuannya yang pertama untuk melakukan latihan pada kompresi sangkar torak, lalu membuang sekret, postural drainase, dan latihan pasif untuk mencegah kekakuan. Nah, dari sini ada latihan level selanjutnya, ini adalah latihan otot-otot pernafasan, otot-otot inspirasi pernafasan. Dan ini untuk menjaga kekuatan dari otot-otot tersebut, karena biasanya pada pasien yang kondisi pasif banyak menggunakan alat ventilasi. Lalu di sini latihan yang cocok adalah deep inspiration atau pernapasan dalam dan quick expiration, atau di sini kalau mungkin Bu Suci nanti akan lebih menjelaskan lebih lengkap nanti di materinya. Lalu selanjutnya di sini ada latihan untuk hyperinflasi. Jadi di sini bisa dibantu juga menggunakan alat seperti Anda lihat di PPT-nya, yaitu alat seperti itu untuk pernafasan inspirasinya lebih besar lagi. Lalu kemudian mobilisasi pada sangkar torak ya, karena biasanya otot-otot sangkar torak sudah mulai kaku. Latihan batu efektif untuk membantu membuang sekret dan mulai latihan early mobilization. Okay, thank you. You can continue from now. Yes.
Okay, so for the next part, we talk about when patient they have improving to the level 2 to level 4. For level 2 patient, for this levels of patient, we will start to doing some physical training. And the physical training here, we included the best strengthening exercise for upper extremity, lower extremity, and also functional activity retraining, and trying to doing some ambulations. And also we have to train for patients' pulmonary function, so we will also doing some diaphragmatic breathing. And to remember that the patient is continually receiving a mechanical ventilatory assistance or using of the oxygen supplement during the training. Okay, so first one we are going to introduce is the bicep strengthening exercise of the upper extremity. In here, we will starting to doing some joint RM for the wrist, the elbow, and shoulders, and for 10 repetition for the each motion per set for 2 sets. And the patient will start receiving the RM exercise in a supine position, and to do like anti-gravity, and then gradually progress to a sitting position as tolerance. And remember, we say that level 2 is sitting on the bed. And to level 4, the patient is able to transfer to a chair. So, and for the different levels, because of they are combined with other physical challenge, because sitting in a bed, actually patient could lay on the bed, so it's just maybe using a little bit of trunk control. And when sitting on the bedside for the level 3 patients, the patient will need more body controls. And for the level 4 patient, they transfer to the chair. They may also need some maybe some pelvic control, the trunk control to maintain their balance. So for the different levels of patients, with their different physical condition challenge and comparing with the extremity exercise, it could also provide them different levels of the training. Okay, so this is the first part. For the upper extremity training, we will try to ask patient to do some active RM exercise and during and under different kinds of the body positions. Okay. And the second one is the lower extremity. For lower extremity, also patient could perform some active RM exercise, and the intensity are also mentioned here. And then the patient usually to do in the supine position for anti-gravity. However, this is a recommendation from the research. However, for a level 3 or level 4 patient, for level 3 patient, it is a little bit dangerous for them to sit on the bedside and only using one leg to balance their body if they're trying to do all of this exercise. So for the level 3 patient, it's still able to perform these kinds of activity in sitting position. However, the safety concern will be it's very important. So for a physician, it is able to control patient's body using the maybe holding on their shoulders, and trying to make the physical therapy when patients are performing this kind of the lower extremity exercise and sitting on the bedside. It is important to keep their safety by controlling their bodies and also be aware of the height of the beds. If patient was sitting too high, and also the bed in the ICU, we know it's pretty soft, the patient might slide down and have some falling incidents. So in this part, always remember to keep patient safety as the first priority. Okay. So for the third one is the functional activity retraining. It is that the patient is turning because this is functional activity, and for this part the patient will trying to doing some movement, and this might help them further to trying to do some transfer or to do some posture changings. So the first one is we will training patient to turning from side to side on the bed, and because the turning side to side from the bed is the first part, the patient will sit up on the bedside. So this was the first priority we're trying to training. And when patient are able to do the rolling on the beds, the next step will also training patient to do a transfer from the bed and chair. However, for all of this above exercise, we are not recommended patient to do it alone. Remember, always remember, ask the patient to perform all of this under supervise. Okay, so the third part, we'll try the patient if able to do the transfer. The third part, we were trying to training patient for the standing. So for standing on the bedside, it is also important to providing some supported, because patient may be immobilized for long times, and although they're starting doing some strengthening exercise for the upper and the lower extremity, their muscle force might not be enough for them to maintain a standing position. So also remember to provide some supported when they're trying to training to the standing up from the bedside. And then the next part is the maintenance of the standing position. And if patient's physical function is more higher than, if the patient's physical function is better, we will try to ask patient to doing some stepping, and also remember to keep them to keep their safety, not to have any falling incidents. Okay, so for the next one is the ambulation. So patient, when they starting to doing the stepping, because we note about the gaits, during the gaits, it has a phase that patient need to be performed the single leg standing. It's like during the other legs during the swing, is performing the swing phases. The one leg is performing the swing phase, the other must to perform the single leg standing for like maybe 1 or 2 seconds due to patient's physical functions. So the patient, as the last part we ask about when patient is able to maintain a standing position, the patient should start doing some stepping. It's for the next stage, the ambulations. So when patient is able to perform the standing, the ambulation will much more easier to start it. And it should be started as early as subject could tolerate. Because in the ICU, sometimes we see patient maybe under a major surgery, like for maybe 3 or 5 days. The physical therapy are very eager to ask them to start to walk. And patient might connect it to lots of the life support machines. And for some old concept before, they might think that the patient is pretty weak. We should let them rest, or we should let them recover to a certain level to start the movement. However, the research now starting to do in the early mobilization, and lots of the research had indicated that the more immobilized period, the weaker patient will gain. So the ambulation, like this kinds of the activity, some people will think it is actually pretty high intensity for patient who just underwent the major surgery. However, it still need to be conducted as early as subject tolerance. So as the patient, their vital sign, their physical level is stable, then we should start to doing the ambulations. And during the ambulation, oximeter and the portable ECG should be used to monitor patients' physical conditions. And if patients is suffering from any unstable physical condition, then we should rest and also providing some the oxygen to stabilize patient's status. Okay, so the final one is the diaphragmatic breathing. So why the diaphragmatic breathing is important is because diaphragm is a very important muscle for our breathing, because it is a spontaneous muscle. When diaphragm contraction, we inhale the muscle, and diaphragm release, we will spontaneously exhale the muscle. So diaphragm is actually it's not a majorly respiratory muscle, but it helps our spontaneous breathing very frequently. So for the diaphragm, because the patient in the ICU, they use the ventilation machine to help them breathing. It's use the pressure to generate the chest wall expansion. The diaphragm may suffering from weakness for a long time. So before patient trying to unwinding from the ventilation machine, it is also important to conduct the diaphragmatic breathing training. So diaphragmatic breathing training is conducting during the spontaneous breathing hour. Before patient is weaning from the ventilation machine, we will starting to have some spontaneous breathing hours every day for the patient to trying to breathing on their own. And if patient could breathing wellly during this kind of phase, then we will start to considering trying to extubation. So the diaphragmatic breathing is conducting at this period, and we use hand to induce the diaphragmatic breathing, and the movement of the abdominal is that when patient is breathing, we will place our hands on their chest and on their abdominal, and we will ask the patient when they inhale the air, it has to see their abdominal has elevated, but not the chest wall. Because using the chest wall, that means it didn't use their diaphragm to breathing. So the first part is using a hand gesture to help the patient to breathing, using their diaphragm to breathing. And the other technique is providing a quick stretch to facilitate their breathing. So when patient could breathing to use their diaphragm to breathing fluently, like that is their abdominal could have the elevation during the breathing. When patient inhale a deep breathing, and to stop when patient is doing the breathing, when patient is exhale their air to the deep part, and then we'll place our hands on patient's chest wall, and when patient is breathing like he's okay, inhale the air and exhale the air, and start the next breathing, we will do a quick stretch of their chest wall and their abdominal to facilitate the muscle to contraction and to do the breathing more sufficiently. And for diaphragmatic breathing, you will start to do it in the supine position. That is most easier for patient to observe their abdominal movement. And then conduct into a semi-folded position, that is a semi-sitting position in like 45 degrees, like sitting in the bed for the level 2 patient here. And then we will conduct it to do it in a sitting position, because during the sitting position, our trunk is a little bit slouched back, so the abdominal movement will be more challenged for the patients. So we can follow this sequence to training the patient to help them to regain their diaphragmatic force better. Okay, I will pause here for you to explain to the student.
Okay. Thank you. Saya akan menjelaskan sedikit. Di sini untuk latihan tadi sudah kita bahas untuk latihan level 1 sampai dengan 2. Ini dilanjutkan dengan latihan level 2 sampai dengan 4. Dan di sini targetnya adalah pertama penguatan. Nah, penguatan ini meliputi penguatan pada upper extremity dan lower extremity. Nah, di sini untuk targetnya untuk upper extremity itu adalah otot-otot pada wrist, elbow, dan shoulder dengan 10 kali pengulangan selama 2 sesi. Dan di sini poin utamanya adalah otot-otot anti gravitasi yang dilatih dan latihan duduk jika memungkinkan. Sedangkan untuk latihan bagian lower extremity itu pada bagian ankle, lutut, dan paha. Jadi knee, ankle, and hip. Nah, karena di latihan bagian lower extremity bagian bawah ini beresiko pasien untuk jatuh, nah di sini butuh pengawasan fisioterapi. Untuk dosisnya sama, hampir sama dengan latihan penguatan otot-otot di upper extremity. Kemudian ada latihan fungsional, ya, fungsional latihan ini dimulai dengan latihan berguling, latihan transfer, latihan berdiri sampai dengan berdiri sendiri jika memungkinkan. Lalu ada ambulasi. Ambulasi itu di sini parameternya sebelum latihan ambulasi, pasien harus bisa berdiri di atas 1 kaki selama 1 sampai 2 detik. Mengapa ini penting? Karena pada pola jalan atau gait pattern itu ada bagian di mana kaki harus tubuh menumpu pada 1 kaki. Dan ini pasien harus kuat. Dan untuk latihan ini pun butuh pengawasan dan bantuan fisioterapi. Jadi di sini teknisnya bisa shoulder dari terapi ini dari pasien ini kita jaga supaya tetap tegak. Lalu yang terakhir itu latihan diaphragma breathing. Di sini latihan ini digunakan karena biasanya pada pasien tersebut dia sudah cukup lama menggunakan alat, dan di sini yang bergerak biasanya sangkar toraknya karena penggunaan alat tersebut. Nah, sedangkan otot-otot diafragmanya tidak bekerja. Nah, di sini cara melatihnya adalah dengan menggerakkan otot-otot diafragma dengan tangan diletakkan di daerah perut. Dan selanjutnya ini ada latihan quick stretch. Latihan quick stretch ini untuk memfasilitasi pernapasan supaya lebih baik. Dan di sini ada langkah-langkah step-stepnya, itu mulai dari supine, perlentang, lalu half lying ya sepertinya itu, semi forward, dan kemudian sampai dengan duduk. Oke, thank you. You can continue from now.
Okay. So for all of this training here, it is recommended to conduct for like 30 to 40 minutes per section and 2 sections per day. because in Taiwan, our ICU visiting time is two times per day. So in here, we also recommended for physician to do the training section for 2 sections per day. And we should conduct it in 3 to 5 days per week and rest anytime if patient is needed. So this is the intensity for the chest for the early mobilization for ICU patient. Okay, so in here you could see this is the actual patient underwent a rehabilitation program here. So so everyone should see in here for the picture A. Everyone is able to talk that for this patient, the patient is it's a level 3 patient because the patient is able to see on the bedside. And we could see the physical therapy here is trying to put a belt on patient's eyes to the first, like we say, the first priority is a safety concern. So it's when started, your physical therapy is recommended to provide safety belts on the patient's eyes. To if patient is trying to falling down, we could use this as this, trying to hold the patient not into falling down. Okay, so the part 2, the patient, because patient is lying down for a long time, and when starting to do the early mobilization program, the patient to sit up for a while, and we maybe ask some family to help patient to sit for a while. Like here, the patient, if the patient sitting on the bedside is not so stable, when we could ask someone to stay back to back with them, like this. And for a while, for patients' vital, because some critical ill patient, when they start to doing some movement, their vital sign could alter vigorously. So we'll like that patient to sit for bits for their vital sign to be stable. That is the picture B we're showing. So for the picture C, for this patient, they are trying to help the patient to transfer into the chair next to the bed. So let's see. Oh, sorry. So for this one, the family and the physician will help the patient to standing up from the bed and then moving to the chest bedside, moving to a chest beside of the bed. So in here, we could see like for this one, for this physician, it is the respiratory therapist here, trying to trying to control all of the ducts of the tube for the ventilation machine, and also we will have lots of the family to help. So when patient is performing early mobilization, it's actually good for the family to join together. One is that when the physician didn't come in the weekend, the family will know how to providing some general physical therapy program for the patient. And the other part is that we have to let the patient to also join the rehabilitation, to giving a physical support for the patient, for psychological support for the patient to performing all of this programs, because the early mobilization program is actually pretty stressful for the ICU patient, because they are pretty weakness and maybe have some psychological problems. And if they all conducting the early mobilization with some foreigners, they don't with some patient that he is not familiar with, the patient motivation will be pretty low. So it is also a strategy to using the family to encourage the patient to conduct the early mobilization. It is a strategy. If all of you will have to perform the early mobilization, is a way to improve patients' motivation. Okay. So finally, we're trying to talk about the contraindication for the early mobilizations. Because the patients stay in the ICU, they are critical ill patient, and their vital sign could alter really fast. And some patient is stable today, however not stable for tomorrow. So it is important to recognize some of the contraindication for early mobilization. Although it could help the patient to regain their physical function to stay in the house. However, if the patient's condition is really bad, we still have to let them rest first. Okay, so the first condition we talked about is the cardiovascular. If the patient required a high dose of vasopressors, then the patient is not suitable for the early mobilization. It is because that upon being stimulation by doing some physical activity, the bedridden patient will, with a long stay at the hospital, will require the additional cardiovascular work to maintain the blood pressures, cardio output, and adequate and consistent cerebral blood flow to maintain their whole body's functions. So if the patient who has prescribed for a vasopressor be aware of their vital parameters, it might not stable. So for this kinds of patient, the early mobilization will be a wait and watch to see if the patient's status is stable. If the patient is not stable, do not study their early mobilizations. And the second one is the respiratory contraindication. The first one, if the patient's SpO2 is lower than 90%, because then for these kinds of patients, do not start their early mobilization. Because for patients in the ICU, they usually connected to the ventilation machine, and they usually is using the oxygen. So if patient were using the oxygen but still having the SpO2 level lower than 90%, that means this patient's pulmonary function is extremely unstable. So in these kinds of patients, do not start in early mobilizations. And the other one is the inspiratory oxygen fraction is higher than the 0.6, or their positive and expiratory pressure is higher than 10 centimeters of 2 centimeter oxygens. Then this kinds of patient also shouldn't start the early mobilization. The FiO2 is the list we could see in the wall. It's the oxygen supplier on the wall. And if patient is using the oxygen higher than 60%, that means the patient's function is actually pretty bad. He has used to 60% of oxygen to maintain their vital sign. That means the patient is extremely weak. So in this kinds of patient, do not start early mobilization. And for the PEEP, the positive and expiratory pressure, it is index we could see on the ventilation machine, and it is usually controlled by the it is usually maybe observed by a respiratory therapist. So you might see this in patient's chart. For the PEEP higher than 10, in this kinds of patient, it also indicates that the patient's expiratory pressure is pretty high. That means the pressure using their breathing has using the ventilation machine pretty much. That means the parameter they use is pretty high, that patient has to dependent on the ventilation machine a lot. So in these kinds of patients, they are also pretty weak. So do not start early mobilization for these kinds of patients. Okay, so the third part is the neurological contraindication, is that if the patient's intracranial pressure is higher, then do not start it. Or the patient is deeply sedation, then because the patient must, because their status might be the crucial or the critical. So in these kinds of patients, we also do not start it to do the early mobilization. And then also if the patient was paralyzed or paralysis, or if they have some cognitive dysfunction, or maybe they have some abdominal brain perfusion, or continue using the brain monitor. In these kinds of patients, for the cognitive dysfunction, because these kinds of patients might be difficult to communicate with, and when we are performing the early mobilization, it is actually pretty high risk. If patient couldn't follow in your orders, then doing the early mobilization will be extremely dangerous for them. So for these kinds of patients, even their physical activity is able to perform, we still not recommended to do the early mobilizations, unless you have pretty much people to help you to control the patients. And for the abnormal brain perfusion or using of the brain monitor is because that using the brain monitor or the brain perfusion abnormal, they have some machine is connected to their brain. And in this kinds of patient, if they're trying to do any movement of their bodies, the machine to monitoring their brain levels is not suitable for the tube to suffering from any movement. So in these kinds of patient, because they have the brain monitor or brain maybe some perfusion tube. So for these kinds of patient, to start in the early mobilization is dangerous because any damage to the brain tissue might cause the worsen outcome. Yeah. So for these kinds of patient, early mobilization is also the contraindication. Okay. Should I pause here or should I continue? We only have one slide left. Okay.
Yeah. I will try to explanation. Ya, ada sedikit poin yang bisa saya ambil di sini tadi. Untuk latihannya tadi yang di slide sebelumnya itu latihannya 30 sampai 40 menit dosisnya selama 2 sesi per hari, 3 sampai 5 hari seminggu, dan istirahat jika perlu. Dan di slide berikutnya itu ada gambar pasien. Nah, di sini bisa dilihat pada pasien tersebut dia menggunakan pengaman, yaitu berupa ikat pinggang. Nanti kalau hal ini menjaga atau mencegah dari posisi pasien tersebut terjatuh. Jadi kalau mau jatuh bisa dipegang bagian ikat pinggangnya itu. Dan dalam latihan tersebut juga ada lihat itu ada tidak hanya fisioterapi tapi juga ada bidang kesehatan lain, ya. Lalu ada juga di situ keluarga pasien yang dilibatkan dalam latihan. Nah, mengapa pasien ini dilibatkan dalam latihan? Strategi ini digunakan untuk yang pertama supaya keluarga juga tahu latihan yang diberikan. Yang kedua, ini juga secara psikologis itu memberikan support kepada pasiennya. Karena biasanya pasien ini dia mengalami depresi secara mental karena proses ICU ini biasanya dia kondisi mentalnya mengalami penurunan dan motivasinya rendah. Jadi diharapkan dengan melibatkan keluarga pasien nanti pasien akan lebih termotivasi untuk latihan. Lalu yang selanjutnya itu adalah kontraindikasi dari early mobilization. Jadi kontraindikasinya adalah di sini jika kondisi pasien itu tanda-tanda vitalnya tidak stabil. Kalau tanda-tanda vitalnya tidak stabil, maka kontraindikasi untuk pemberian latihan tersebut. Yang kedua itu ada parameter-parameter tertentu yang tidak membolehkan pasien untuk diberikan latihan early mobilization. Jadi misalnya di sini kandungan SpO2-nya lebih rendah dari 90%. Lalu FiO2 itu lebih tinggi dari 60%. Nah, FiO2 ini berarti kalau dia lebih dari 60%, maka pasien membutuhkan oksigen itu cukup besar. Padahal latihan ini nanti akan beresiko pasien ini mengalami gangguan juga. Lalu di sini kondisi neurologikal. Di sini ada beberapa kondisi menjadi kontraindikasi latihan. Misalnya di sini ada kondisi paralisis, lalu gangguan dari kognitif berpikir, karena biasanya kalau kemampuan berpikirnya mengalami gangguan, ini pasien jadi sulit untuk dikendalikan gitu. Lalu di sini pasien yang menggunakan monitor otak secara terus-menerus. Nah, pasien yang menggunakan monitor otak ini dia biasanya untuk bagian otaknya ini mengalami perlu adanya perhatian pengawasan secara intensif pada bagian otaknya. Nah, padahal kalau latihan ini beresiko nanti akan merusak dari otaknya tersebut. Kalau dia otaknya itu sensitif atau mengalami gangguan. Okay, you can continue from now.
Okay, This is a live slide that I have to provide you a little bit concept of this. That early mobilization is a multiple discipline approach. So the early mobilization need multiple discipline to cooperation, and we need the doctors to provide a certain diagnosis and monitoring patients' disease progressions. And nurse who stay with with the patient all the time are pretty familiar with patients' physical conditions. And the respiratory therapist adjust the patient's ventilation machine. So if you want to start training patients during the spontaneous breathing, or we want to try to do a winning training, it is better to performing with the with respiratory therapist. And also neurologists to know the patient's calorie intakes every day. So it is also recommended to understand patients' daily in-care in order to provide the proper exercise intensity, but not overtraining the patients. So for early mobilization, we have to remember that it is patient-oriented, always takes patient's benefits first. And also during the different professional, we need to have the good communication with each others. Because if the patient has any problems, then all of us have lots of works to do. And then also remember that with your training program, it has to be detailedly write down on the chart for the others to understand what kinds of the program patient has underwent today. And if patient has other problem like after your treatment, the patient sleep a lot, and the nurse will know, oh, because this morning he's trying to do the standing, and it is actually pretty tired for the patient to sleep. Then the nurse will know, okay, this is normal. We don't have to talk to the doctors, or I just have to monitoring his vital sign to be stable. That will be fine. So chart writing is also very important. And then regular meeting with other professionals to help you to discuss with patients condition and trying to understand for the other problem. Like for patient, maybe patient will starting to do other programs, other treating program, or starting to using other medications. We could to know all of this information during a regular meeting. Finally, this is intervention that will need the cross-professional supported, because we need others' information to provide the best prescription for the patient. So always remember to have a good relationship with others professional. Okay, so this is the end of today, and I'm sorry for a little bit delayed. And if you have any question and we don't have time for the QA, then you could send the question to me and I will answer it in the paper.
Okay, thank you. I will explain it first.
Sure.
Oke. Di sini yang terakhir adalah bagian akhirnya. Di sini menjadi kesimpulan akhir bahwa untuk pasien dengan early mobilization ini perlu adanya multidisipliner, pendekatan secara multidisipliner. Jadi tidak hanya fisioterapi, tapi juga tenaga kesehatan lainnya, mulai dari nutrisionis, dokter, perawat, sampai dengan di sini kalau di sana ada namanya terapis pernapasan ya khusus. Nah, poin-poin penting di sini adalah yang pertama, semuanya berorientasi pada pasien, tujuan utamanya. Dan yang kedua, komunikasi yang baik. Dan yang ketiga, ini perlu adanya catatan medis yang cukup mendetail. Jadi termasuk di sini salah satunya itu adalah waktu istirahat pasien. Jadi dari catatan medis itu misalnya pasien tersebut pada jam 9 pagi misalkan dia biasanya tidur. Maka di sini misalkan kita mau latihan berarti selain dari jam-jam istirahat pasien. Jadi catatan medis yang detail ini menjadi penting. Lalu kemudian pertemuan secara teratur, dan yang terakhir di sini perlu adanya support dari profesional lintas profesional. Jadi saling mensupport ke pasien. Oke, selanjutnya sesi tanya jawab. Jika ada yang bertanya, silahkan. Nanti akan dicatat di sini. Oke, I have explained all the lecturer. Now the question and answer session. Oke, jika ada yang bertanya dipersilahkan.
Hello,
Yeah.
Miss Wang.
Yes.
Could you tell us please about ventilator weaning protocol? And is there any parameter for each level in physical therapy?
You mean the protocol?
Weaning.
The meaning of the protocol, which one?
Yeah. Ventilator weaning protocol.
Oh, you mean
Is there, yeah.
The ventilator?
Yeah, ventilator weaning protocol. Are physical therapy in Taiwan do that weaning protocol or it do by nursing?
So you mean for the patient to try the weaning, what's the parameter, right?
Yep, yep.
Okay, for this part, the patient trying the weaning, because in Taiwan now we have the RT to adjust the ventilation machines, and the patient will have the spontaneous breathing period if the RT thinks their parameter is suitable for them to adjust. So in Taiwan, in this part, we have actually separated professionals. Yeah, and for patient, because we were trying to unweaning, we will see. We trying with each study to do a try weaning. Then we will if the patient could underwent the spontaneous breathing for like 2 hours, then we will starting to do the weaning training. Yeah, so basically it's just following the time. Most of the machine's parameter is controlling by the RT. Yeah.
Okay, thank you, Miss.
Ya, silakan yang ingin bertanya bisa melakukan raise hand atau nanti bisa menulis di chat. Silakan. Iya, nanti jika ada kesulitan bisa saya bantu untuk mentranslate ke dalam bahasa Inggris.
For the question you mentioned before, I could ask my friends of RT and to respond to you. It's okay?
It's okay, no matter. So maybe there is any tips for us as a physical therapy to make it faster, to make the weaning process faster.
To make what faster?
To make weaning process faster.
Oh, I think the diaphragmatic training here, the diaphragmatic breathing is pretty important because for patients to immobilize for a long time, their respiratory muscle degenerate really fast. And the diaphragmatic training, because the diaphragm muscle, when the diaphragm muscle contraction, the lung will spontaneously expanded, the air will flow in. And when the diaphragm release, the lung will recoiling back and to aspirate the breathing. So for the diaphragmatic breathing, if the diaphragm has contraction efficiently, the patient respiratory will be pretty weak. So because I have talks about the other topics of COPD, for these kinds of patients, we also recommended for diaphragmatic breathing to have a better lung inspiration to help patients to breathe. So for all of this physical training, I think all of it is important, but if you have to say about to improve the respiratory function, I think the diaphragmatic breathing will be recommended.
Okay, I will explain about your answer to student. Berdasarkan penjelasan sini, mudah-mudahan tidak salah ya. Yang paling penting di sini adalah kondisi latihan dari pernafasan diafragma. Karena penggunaan ventilasi alat ventilasi terus-menerus, biasanya kondisi pernafasan pasien ini mengalami penurunan yang signifikan. Maka latihan yang paling penting di sini adalah latihan pernafasan diafragma. Oke, thank you. I think the time is already in Indonesia at 11:30, and we almost prayed at 12. I think it's enough from now, from your presentation. Thank you for your time, and maybe if we have some question, we can contact you, maybe for email or anything.
Sure. I will provide my email in the conversation. Yeah, sure. Okay, so this is my email. If anyone has question, please feel free to mail me and I could explain it to you fully.
Okay. Thank you for your time, Miss Po Ching Huang. I am as presenter. Say very much thank you for this lecture, and maybe Mr. Rahmat Rosadi as a closure.
Udah keluar dia. Udah Jumatan, soalnya di sana udah jam 12 lebih kan.
Oke.
Kamu udah? Ira udah keluar. Oke.
Okay. Thank you for your time. I think this is enough for us. This meeting is over. Maybe we can see and talk each other in the next meeting. Here, say goodbye and thank you. Untuk rekan-rekan semua, acara ini sudah berakhir. Pertemuan itu berakhir, semoga bermanfaat. Jika ada yang bertanya, bisa langsung email kepada beliau, tentunya dalam bahasa Inggris. In English, of course, if you email, Indonesia, she cannot understand in English. Dia ini terbuka, dipersilahkan. Terima kasih, saya sebagai moderator. Mari kita tutup kegiatan hari ini dengan berdoa menurut agama dan keyakinan masing-masing. Sebelum saya tutup, mungkin Bu Suci ada yang mau disampaikan?
This one, thank you for joining with us and hope you can join with us again in another meeting. Yeah.
Oh yeah, thanks for the invitation. Thank you. And having a nice day.
Yeah, have a nice day too for you and your family, of course.
Yeah, thank you.
Oke, mari kita tutup acara ini dengan berdoa menurut keyakinan masing-masing. Berdoa dipersilahkan. Oke, acara selesai. Saya persilahkan untuk keluar dari meeting. Ya, terima kasih. Thank you, Miss.
Thank you.
Thank you. Bye-bye.
Bye. See you later.